Let's go ahead and get started. Tom Lee lived here. He died in 2001, almost at the age of 94. He lived a long life. Most of his time was spent in El Paso. This is his cenotaph, which is in the State Cemetery in Austin. He's not buried there, but that's his cenotaph, which means it's a memorial. I love this quote, and I gave this talk last week to Silva Magnet, a little bit different version, but I hope I can read this. Sarah and I, that's his second wife, live on the east side of the mountain. It is the morning side, not the sunset side. It is the side when the day is beginning and not when the day is gone. The best time of the day is the day coming with the work before us, with the eyes wide open, with the heart grounded. So actually, George W. Bush, the second George Bush, he used this quote when he was at the Republican convention in 2000. So he was quoting the Franklin Mountains, actually, the east side, the side that's opening up the new day, not the sunset side. And that's what George Bush was talking about, how, you know, the United States is still growing and prospering. So I thought that was very, very, I always think of this quote, especially when I look at the mountains up here in El Paso. So we're going to focus on his war years. So who remembers when World War II even occurred? Okay, how about this side? What year did it start? Oh, okay, so next slide. It actually, from 1939 to 1945, a long time. The United States entered the war in 1941. After what event? You got to know this one. The high school students knew both these questions the other day. Pearl Harbor, December the 7th. Franklin Roosevelt, I think actually it was December the 8th, that they declared us to be at war with Japan, and then shortly thereafter with Germany. So I just want you to get an idea of the magnitude of all the deaths and the injuries. So just looking at the United States deaths, over 400,000 men and a few women were killed. These are the military. Almost 700,000 people were injured of various types from the U.S. side only. When you look globally, 15 million military deaths. 15 million. You can't even fathom that. I can't. Military injuries, 25 million, and civilian deaths worldwide, you know, the Holocaust and all the other people that died, 45 million. I mean, that's just crazy. You know, population of the United States is about 315 million now. That's almost a sixth of the whole population that we just think about. I mean, people died. Next slide. You saw this picture on the billboard all over the city. I had no idea, first of all, where this place was located. Didn't know anything about the events that occurred there. I couldn't even say it. I got on the internet, I heard it pronounced 3 different ways. So PELELIU is probably the most common way of saying it. It's a small island in the Pacific, about 2,000 miles from Japan, and just under 1,000 miles from the Philippine Islands. And it was a major battle. And actually, the U.S. thought they were going to take care of this island in 4 days, but Japan really held strong, and it took 3.5 months for them to successfully occupy the United States to win that island. There were 10,000 Japanese soldiers killed there. There were 10,000 casualties on the U.S. side. 2,000 of the men died, and almost 8,000 had suffered various injuries. So it was a very bloody battle, and actually, in retrospect, from a strategic standpoint, it wasn't that important because the U.S. had already moved past that area as they were conquering the other islands as they were getting ready to attack Japan. And before they had to attack Japan, as we know, the 2 Hiroshima and the Nagasaki bombs were deployed. But they we thought we were going to win this battle real quick, and that was the other criticism. It just took so long because the Japanese had already learned how to adapt to the island warfare. Next slide. So these 2 slides here, this is his rough sketch. So everything he drew in World War II were real events, real people. He didn't just like, well, I'm going to just try to make some kind of picture. He actually said he saw this soldier come at him, staggering towards him, and then he collapsed and died. I'm going to be honest, at 2 o'clock this morning, I got a trauma activation on the guy that accidentally intentionally shot himself. We'll talk more about that later. His face reminded me of this guy. It was terrible. And that's why I spent a lot of my hours this morning dealing with him. Next slide. So I love this picture. I mean, it's very graphic. His artwork from World War II is extremely graphic. I hope I don't offend anyone. So this is a military chaplain. He's going over and seeing this gentleman putting the blanket over him. Obviously, the man had died. In his right hand is the Bible. In the left is a canteen of water because he was giving water to the injured troops. We're going to talk about something. So what I'm going to do is bounce around. I'm always good at bouncing, or maybe bad at bouncing around when I talk. I don't talk in a logical, sometimes, sequence. So I'm going to go what was going on during the war and what we learned from the war, what we do now, what has been good, went away and came back. So this is one thing. It says stop the bleeding, protect the wound, and prevent shock. Next slide is probably more important. So these are all pictures that came out of World War II, how they instructed the troops what to do in case they were injured or their comrade was injured. Pressure points: carotid artery, jugular vein, the brachial vessels, the groin. Put your hand, stop the bleeding, okay? This is like in 1942. On the left here, I know it's a little hard to see, they're talking about putting tourniquets in place on extremities that are injured. So when I was a medical student and a resident, I was taught, do not use a tourniquet. A tourniquet is dangerous. If you do that, the guy will probably lose their leg. So we were taught, do not use tourniquets. One reason, because we did them the wrong way, and we put them on too tight and too long, and we did makeshift tourniquets with sticks and stuff like that. But they actually, in World War, actually even in the Civil War, in the World War I, they were using tourniquets, and they used them in World War II. This slide here, what do we see? Stop the bleed. You saw that in 2 slides before in World War II. We came back with this phrase, and unfortunately with all the active shooter incidents, mass shootings, we're using tourniquets again. There was something known as a Hartford, Connecticut consensus statement where a lot of trauma surgeons got together. They reviewed the data from Sandy Hook. Does everybody remember Sandy Hook, Connecticut? Unfortunately, 26 people lost their lives, 20 were very young children. When one of the lead surgeons, he actually reviewed all the autopsies, and he found out a lot of these children probably could have survived if somebody would have put tourniquets on these kids. So that's why we're starting to do Stop the Bleed. So I'm going to have a video here, hopefully if it works, to show you about Stop the Bleed. This is probably the most important thing I could teach you today, if anything.
A bleeding control course is designed for the public. So it is short, it's precise, and it's designed at the end of the education. The public will have a skill which they can use immediately. We teach 3 things: how to use your hands to stop bleeding, how to use a hemostatic dressing, which is a gauze impregnated with a substance that can stop bleeding, and then how to use a tourniquet. With those 3 things, most people can slow down or stop severe hemorrhage. And all you need to do is stop it for long enough that, in fact, a first responder or an emergency medical person can take you to a trauma center.
So this is the big deal with the American College of Surgeons and various trauma nursing societies and even emergency medicine societies that we're pushing to do these Stop the Bleed courses. So far in the El Paso regions, we've got over 3,000 people trained on how to do this. If you go to most hospitals, you'll see something in various areas that say Stop the Bleed. These are kits that have tourniquets. These are in hospitals because we have active shooters in hospitals. The state of Texas in the last legislature has mandated that every school have these kits in their various locations in their schools, but I'm not sure if it's all the teachers, but the preponderance of all the teachers have to learn how to Stop the Bleed. Pretty much all the DPS troopers, police officers, FMS, Fire and Medical Services, Fire Department, they're all learning to do that. So we've been teaching that across the state. It's a mandate now with all the schools. It's sort of sad that we have to do this, and it's actually sort of sad that we have to put tourniquets in our own hospitals in case we have an active shooter in our hospitals, but many of the school districts have it. Public venues will have them. All the police troopers now carry. I actually have one in my car. But if you don't have the kit, just use a belt. Or first, just pull your shirt off, cram your shirt down on that person's bleeding. You should be able to stop the bleeding, especially if it's a vein that's bleeding. If not, do the other thing. Next slide. So, any question about stop the bleed, please try to take the course. That's sort of like, in the 60s and 70s, we learned how to do CPR and, basic life support. This is now part of it. If you go to Texas Tech and various areas where we have defibrillators, we're going to have stop the bleed kits. So it's a sad statement. On August the 3rd, 2 patients actually came. They didn't come to our trauma, UMC's trauma center, but 2 went to Del Sol with tourniquets on. When we did our action after review, I thought maybe 1 would have benefited from a tourniquet at our place, but after I looked at it closer, we all agreed that the tourniquet would not have benefited for 2 reasons. 1, the patient was too large to get a tourniquet, and more importantly, the injury was right here in the groin. It got the femoral vein, and that's going to lead to this slide here in a second. Don't leave it yet. So it's known as now abdominal and junctional tourniquets. Junctional in trauma is the groin and the axilla, the armpits, big vessels in both places. So the military came up with this device that we're going to show a quick video on how they're using it. And about 2 months ago, I had not even heard of this, in all honesty. I got a patient that was flown to me from eastern New Mexico, from Artesia. And this guy came on with this tourniquet. They go, we got an abdominal tourniquet on this guy. Actually, they called it a junctional because he had been shot in the groin. I was like, I don't know what the heck this is. So I had to Google it. And I said, I never heard of this. So I asked the trauma medical director, William Beaumont, who's been deployed a couple of times already. And I said, do you know anything about this, Chris? I said, this came from your world, from the military. He says, no, I've not heard of it either. So he's actually going to give a talk on it at our December trauma conference so we can learn about it more. But this is now more sophisticated. Now that guy who actually did okay after several days in our hospital probably would have benefited from a junctional tourniquet because he had completely transected his femoral vein at the Walmart. Go ahead and show the next slide. I think that's where the video is. So that's the more sophisticated tourniquets that are being used now for the abdominal bleeding and groin bleeding or bleeding in the armpit. And believe me, when you get bleeding in that area, that's a difficult place to control. So going back to the tourniquets I was talking about, like I said, when I went to residency, we were taught not to do them. Now I'm probably seeing 3 to 4 patients a month coming to UMC, our trauma center, with tourniquets on for extremity bleeding, either from a gunshot or stabbing, or I know we had one guy had a circular saw that went across his leg and he lost control of it. So it's saving lives. So what we thought was bad is now good again, even though it was a good thing in the Civil War and first couple of wars. Okay, let's move on. So this device here is called a ROTEM, and it's got a really long name, so I'm not going to give the name. It's also the older device was called a TAG. So they used to use this a lot in the 1960s and 1970s in hospitals to help them decide how much clotting stuff they should give, like platelets and plasma. And then it just went away. About almost 15 years ago, it started coming back into vogue with obviously a lot fancier device now that's electronic and stuff like that. And we use this now on every one of our level 1 trauma patients that come in. And we even were able to use it that day on the mass casualty. We got 14 patients that day in under 2 hours, or actually under 34 minutes. So when I actually tried to get the hospital to buy it, everybody said, no, this is crazy. This is old stuff. Nobody uses this. Nobody wants this. Now it's mandated by the American College of Surgeons for every trauma center to have this device in their hospital. We now have 2, and we're about to purchase a 3rd one. So it tells me to be what type of blood products I want to give my patient. This tells me this is real skinny. I need to give this guy plasma, platelet, FFP. This tells me he needs platelets because this little green is too short. This tells me that I'm actually okay with not giving some chemical agents. So instead of me just pouring in blood like I used to do, I get this device and 10 minutes later I get an answer, and then I keep using it until the bleeding is stopped for the most part. So it's really nice. We don't waste as much blood as we used to. Surprisingly, when we got our 14 victims, we only used 59 units of blood that day at our hospital. We used 38 units of plasma and 10 packs of platelets. I don't want to give you all the data on Del Sol since that's not where I work. Their numbers are very similar. They got 11 patients, we got 14, and they used about the same amount, a little bit more, but very similar. And I know they use this device also. Keep going. So we're going to switch gears a little bit. I'll let you read this. And then now focus on this guy's eyes. What do you think about his eyes? Very just staring off into space. His pupils are dilated. What do you think's wrong with him?
PTSD.
Very good, thank you. Post-traumatic stress disorder. Very, very common. In the Civil War, when these guys had this, they thought, well, they're cowards. In World War I, they shot some people for it. And now we know it's a very common disorder that the military suffers. And I know the current group suffers for it. My father was in World War II, he was in the Navy, and I know his ship was sunk at least once. And my mom always told me, my father passed away about 15 years ago, that they could never go see a war movie when it was on TV, because I used to like to watch it as a kid. He'd always change the channel, and I didn't know why. My mom said, oh gosh, when he came back and the years afterwards, he would just start going cold sweat. I had no idea what that was called as a kid. So that's what he had, which unfortunately a lot of men suffered, and they still do. Next slide. So this picture is actually his sketch that he did when he saw this guy out there. And if you just Google PTSD military, you'll see pictures from Iraq and Afghanistan that look just like that, those eyes just wide open like that, just looking off into space. And this is called Bloody Nose Ridge. Actually, that was one of the mountains at the island, and where a lot of men died during that battle, and that's where he saw him coming down from the mountain. Next slide, Renee, thank you. So this was in 1941. This is a pamphlet that the soldiers would receive. And they always got all these little informational brochures and stuff. So they called it basically psychoneurosis back then, fancy word for PTSD. So I'm going to show you this graph here. From 1907 to 2017, this is not the military, this is suicide rate. I always thought growing up that suicide was a very recent phenomenon, that it didn't happen. And I do a lot of genealogy work. And I go to cemeteries and I hear like, well, why did this person die and stuff at a young age? Or why did she die or whatever? If they didn't die of illness, so many of these people died of suicide because they didn't have ways of treating it back then. I know it was a stigma with suicide and stuff, but it actually did happen. And but look at the Great Depression occurred in 1929. See the peak then. And then World War II. World War I was around 1917. And then it tapered off. Unfortunately, in the last 20 years, it's been on the increase. And I know just recently it came out how high the suicide rate is now with teenagers and people just going off to college. So if you have concerns about yourself or a friend, please seek help. My wife is a doctor. She's an intern. She told me earlier this week, not one of her patients, but a teenager that she knows real well has come to her and said, hey, I'm just not feeling good. I've been cutting. And then now she said, I feel like killing myself. So they had to go seek help for her because it's escalating. You go from cutting to other things. And unfortunately, we see too much of that at our hospitals where people commit suicide. So if you're having concerns about yourself, please, it's okay to get help. If you know somebody, please talk to a counselor, somebody help them out. Next slide. So this slide is very scary. This is the rates of suicide in the U.S. Armed Services. And the green is the Army. This is from 2012 to 2017. The blue is the U.S. rate. And actually, we're not one of the higher countries in the world. But look how the military is exceeding us. And somebody said, well, the Army is high because there's more of them. This is not because of volume. This is a rate. So we have a major problem with medical care for people with psychiatric problems. When I say psychiatric problems, depression, PTSD, things like that. And this is the active duty. And we know the veterans are coming back. There's 30 veterans dying a day in this country from suicide. 30 per day. That's just hard to imagine in my mind. So I mentioned at the beginning about the guy that had that face that was all messed up. That was a suicide attempt. Shot himself just after midnight. So we probably see 1 or 2 military at UMC that come in with injuries like that. So we've got to do something for it. There's not enough psychiatrists. There's not enough counselors. We've got a major problem. We have people that are sitting in our ERs. You probably remember that. At our hospital, and it's not just at UMC, we hear about that across the state. They'll sit there 5 to 7 days with a psychiatric problem, depression, and we can't get them to the psychiatric hospital because there's not enough beds. So it's a problem. I don't know how we're going to deal with that because there's not enough financial resources. Next slide. This is the number of suicides per year through 2018. It was it's 2018. And I know it just recently, about a month ago, it came out, the suicide rate is even worse now in the military. It's a problem. Okay, keep going, Renee. So we're going to I do a lot of switching gears. Antibiotics, okay? We didn't always have antibiotics. My great-grandmother died at the age of 20-something from something called Ludwig's angina. It's an infection of the maxillary glands. She had her tooth pulled, and then she got bloodstream infection, and she died in 1918, I think it was, or 1920. And because you can get on the internet, like I said, I do the genealogy. And I see kids that died of appendicitis. I did 2 appendectomies yesterday, and now the patients are home today. These people are dying, like 30% mortality rate, because we did not have antibiotics. And thankfully, after World War I, penicillin started becoming popular, and they were using it like crazy during World War II. And it saved thousands of soldiers' lives, not just the U.S., but across the world. Then the one that actually came before penicillin was Sofadrugs. It started as just a powder. And there's a gentleman, I don't think anybody knows him because he's no longer in El Paso. He's still alive. He's 103 and a half, General Hardaway. He actually was a brigadier general at William Beaumont in the 1970s. He was very active in research in the Vietnam War. But he was at Pearl Harbor as just basically like an intern. And he always told me stories how all these soldiers came into his area and they said, you're going to take care of the least injured because you're the new guy. And he worked for 3 days straight operating. And he's thinking, my God, my first patient I got had his brain exposed. If these are the least injured, I can only imagine how these other guys must have looked. But he did a lot of research with antibiotics and things like that. So we didn't have antibiotics always. So that's a great thing. And there's so many new types of antibiotics, I can't even keep up with them now. Next slide. So what's the problem with all these antibiotics? Overuse, terribly overused. Patients go to their doctor, they got a sniffle, they got a cold, which is probably a viral infection. They all demand an antibiotic, and the doctor doesn't want to fight with them, so they give them antibiotics, or we give them antibiotics that maybe you only need 2 days worth, and they're on them for 2 weeks. So that causes antibiotic resistance. So the bacteria are smart. Their DNA will evolve to be resistant to that antibiotic. So we're seeing more and more resistant bacteria in our hospitals, and we're running out of certain types of antibiotics to treat these people. So that's a little scary. And it's not just for people. We use antibiotics in our feed for our cows and our chickens and our pigs. So that's causing resistance. Anytime you go in the hospital, the first thing you're going to be told is wash your hands, wear gloves. And we have terrible hygiene, including the healthcare profession, that people just don't do it. So we've got a problem, and it's not getting better, it's getting worse. Next slide. I'm going to show you just a few pictures. This is some of the artwork he did. Go ahead. Okay, now we're going to jump over to anesthesia. The stuff in dark is there was no such thing as an anesthesiologist back then. It was just the doctor doing it, and they had techs that were called anesthetists that would intubate, which we have now. They're called CRNAs. That device up there is called a laryngoscope. We still have those little curved things or tubes that we would put down to help the person breathe. The white thing there is an ether mask. They would drip ether through it and to put the person to sleep. In Civil War, they actually didn't even have ether until the end of the war. Or they actually had chloroform is what they had, but it took a while. So this is how we're sophisticated now. This device here is called a glide scope. It's got a little video camera on there where you look and you can actually see everything very nicely as you're putting the tube down, as opposed to the old device that you see there, which actually 10 years ago, that's all we were using. Now, we predominantly use this thing with a video scope. I can tell you at Van Horn, which is not even staffed by a physician, for 2 weeks out of the month, they have nurse practitioners. They have this device, and it's hooked up to somebody in North Dakota when they need to intubate. The doctor in North Dakota can see the NP or the PA in Van Horn intubating, doing it in real time. Like, well, no, put the camera, tilt your deal this way. 1,500 miles plus, so probably about 2,000 miles away doing that. So that's a pretty neat device. This is called propofol. When I was a resident, it just came into being. It was called milk of amnesia because it looks like milk and you would forget. This is how we put almost all our patients to sleep now. Do y'all know which celebrity died because of this drug? Michael Jackson, because they had no airway protection. They would just give him a low dose while he was sleeping. Insanity. You would never use this without a protected airway. Keep going. Another slide, or picture, I'm sorry. Go ahead. Okay. Malaria. Malaria impacted the troops terribly. It was a big deal. That and yellow fever when they were building the Panama Canal. Turn of the century, malaria was prevalent pretty much everywhere. This is in 1940. It was called AN, short for Anopheles mosquito. That was the genus of the mosquito that was going rampant worldwide at the turn of the century. Essentially, everybody got impacted with malaria at some point in their life. They said Abraham Lincoln got it, George Washington got it. World War II, 40% of the troops in some of the battles on the U.S. side had malaria. They were fighting while they were sick. The good news is 90% of the Japanese had it, so they were even more fatigued. So you see this picture here, this mosquito drinking? Who's heard of Theodore Geisel? Theodore Geisel. Who's that? Dr. Seuss. So before he became a PhD doctor, he got an honorary title. He actually was not a physician. He was not a PhD either. He got an honorary degree right before he died, but they just called him Dr. Seuss. But in World War II, he was doing artwork for the military, cartoons and stuff. And there was actually a video of this guy that he drew as a cartoonist. Go ahead, next slide. So this is some of his artwork, Dr. Seuss, not Tom Lee. He didn't do any of this art. There was actually another picture, and it was a lot more risque than this. And, I mean, way a lot more risque, but because the troops were, young guys. I decided not to show it, but it's quite impressive. So it was the Anopheles mosquito that had a parasite in it called Plasmodium vivax, and it would bite you and then transmit the parasite over and over again. So that was World War II. Let's look at the slide now. Look how we cleaned up malaria. So red is really bad. Light red is not so bad. It's pretty much gone from the United States to the North American continent. It's still now in Africa, for the most part, in India, in South America, but nowhere to what it was when the troops were dealing with this. What's the treatment for it? Does anybody remember? Quinine, yeah. So I can't remember ever seeing anybody with malaria. So this is on an aircraft carrier because he was hanging out on it. I can't remember which aircraft carrier in the Pacific. Probably had a kamikaze attack. So once again, I'm switching gears. So using blood is really a fairly new phenomenon. We didn't even know blood types A, B, and ABO and O until 1900 when Landsteiner did it. And shortly thereafter, Rhesus did the RH typing. So we did not give blood, obviously in the Civil War. We did not give blood in World War I. Between 1 and 2 is when we were starting to use some blood donations and stuff like that. And we would either get the blood and freeze it and then thaw it, and with water, actually, not saline, with water. And unfortunately, a lot of this blood was tainted with hepatitis. So these soldiers got hepatitis. Dr. Hardaway, once again, was the one that was telling me how they would give all this blood to these soldiers, and so many of them came down with hepatitis because they didn't know how to check for hepatitis on the donors. So at the beginning of World War II, they weren't even hardly using it because the general said it doesn't help. And secondly, we don't have room in our transport ships and the planes and stuff to use it. We need it for the bullets and the guns and the jeeps and stuff to transport. We don't have room for the blood. So they didn't use blood at the beginning. And then they started using it. And this is sort of like their schematic, how they would transport it around. It's a little complex, but just sort of gives an idea. This is from one of the books that I saw. So next slide. So then they did something called whole blood. So when you donate your blood, the blood bank will take your blood and they'll centrifuge it, and a part of it will be the platelets. They put the platelets aside, and a part of it's the red cells, and then a part of it is the plasma, what we call fresh frozen plasma. So we get at least 3 constituents of blood, and there's something else called cryoprecipitate, which is just clotting factors. Well, in World War II, they found that, we'll just get the guy who donates from somebody. You've even seen pictures of one guy's donating, the other guy's in his other arm. They didn't do that too much, but they would have this whole blood, they would give it to him. So we quit doing that. We partition our blood, and that's how we do things. So that's what they did, and now we partition blood. So let's move on. Before you show the video, hopefully I'll let you work on the video. So now we're doing whole blood again. What was old and popular in the war has now become popular again. Just 2 weeks ago, I met with the blood donation center with their medical directors in Albuquerque, but they supply all New Mexico and El Paso. I said, I want to start giving whole blood to my patients. When I went to our big national trauma meeting called WWII a month ago, that was like the hot topic. We're giving whole blood. Until in San Antonio, the ambulance crews now carry whole blood, and they give it to the patients before they get to the hospital. One of the helicopter crews that fly injured patients to us from eastern New Mexico, Artesia area, Roswell, just last week, they gave me a patient with whole blood before the patient got to me. Yes, sir?
Do they type and cross-match the patient in the ambulance?
No. They give O negative, a universal donor. Now, obviously, you got to be careful with that. You're right. So it's from one donor, as opposed to now, when I give blood, I give all this blood products from multiple people. Now we're trying to get whole blood, and we're going to start doing that at UMC. Yes, ma'am?
Once they get them type and cross-match, do you use the actual...
Specific, yeah. So somebody comes in, we'll give them O negative, especially if it's a female. If it's a guy, we'll give O positive. Or if it's a female past childbearing age, we'll give O positive because we want to save the O negatives for them. So like when the guy came in last night, I gave 2 units of plasma, 2 units of blood. And I said he needs more. I gave him 2 more of each. And by then we were typing cross-match so we could give him his type specific. But yeah, so that's what we do. Yes, ma'am.
Is it just because you just want to limit it to one donor or more for the effects of all of them?
Well, the neat thing about it is,
What's the question, please?
why do I want to give whole blood was her question, as opposed to giving the components. First, it's fresh. The clotting agents are working better. The platelets are still working. Because now when you take the platelets out of blood, you got to keep them at room temperature and you have to circulate them. There's a little device that circulates at a room temperature because if you cool it off, they don't work. And after I can't remember what the lifespan of platelets is in that, I think it's like 7 days now. You wait too long, since it's room temperature, they can get contaminated by bacteria. So that's not a good thing because we call sepsis in the patient. But if we give them the whole blood, you can actually keep the blood cool until the time you use it. So the platelets actually work while it's in whole blood. So it's not, I mean, it's what we, it's real what we have in our body. So we're giving what we're supposed to have. But we decided we're going to partition it out because it was cheaper. Well, a lot of patients don't need the red cells. In all honesty, I use more platelets than I use red cells because I want the patients to clot, especially head injured patients. When they have a bruise in their brain, I want to make sure their platelets are working because our cardiologists give everybody now aspirin, which knocks out your platelets. And even now we have something called Plavix, which is stronger than platelets, are stronger than aspirin. So we got to try to make them sticky again. But now we're moving to whole blood. So this is what the military, this is their video, one of their videos, so I'll show it.
We are the sole provider of blood and blood products for the Department of Defense, for the active duty, for our war fighters, for our beneficiaries, for our military eligible beneficiaries, and even our allies that we serve in the combatant commands. I'm Captain Roland Foy, the Director of the Armed Services Blood Program. The ASBP actually was founded in 1952. It became operational around 1962 and was very, very instrumental during the Korean War for distributing blood and blood products for our Korean War veterans. When you have an injury, traumatic injury, that you have to treat patients, you got to stop them from bleeding, and plasma is that source. Plasma contains all the coagulation factors that you need. Also, platelets that you need are in plasma. Blood, actually, or red blood cells, and the red portion of your blood is really your red cells. It has your white cells in there. And there may be a little bit of platelets in there. The white cell, of course, is helping with fighting infection. The red blood cells is for oxygen carrying capacity to bring oxygen to the tissue and keep that tissue alive. Most of the time, our plasma is collected from whole blood collections. Normally, we will collect a donor from whole blood, and then we'll separate that into red cells and also plasma.
A donor will show up to donate. What we do is do a thorough history on them, physical. They go through a short physical exam to include, blood pressure, temperature, things like that, vital signs. And then, once they're cleared through the questioning, they do the donation process, and that product comes back here to the ASBIC main facility where we do pathogen reduction. It nullifies any of the viruses or bacteria that would actually be in the product. That whole process is done right here at the ASBIC.
The type of plasma that we like to collect from the donor is a universal plasma, which is AB plasma or group A plasma. We can give that to anybody. The benefits of that is, and the difficulty of that is, plasma that is AB from an AB type donor is only 4% in the population. So we have to recruit very hard to get those donors. The benefit of that, of course, is we can give that at the point of injury, and we can give that to anybody that is ready to transfuse that unit of blood.
We have 5 facilities that we ship out to, and they range from the VA, other government facilities, such as Fort Belvoir. We also do what's called presidential support, which is anytime the president travels, he takes blood with him, and we provide that blood for him. We also provide blood for Walter Reed here at Transfusion Services. We deal with fresh frozen plasma, and that's kept on dry ice. These machines, they're refrigerators and freezers, and this is what we use to store blood products until they're ready to be labeled, or after they are labeled until they're ready to be shipped out.
But, if we don't have it for the troops, then we have to get it somewhere. And so that is something that, we want people to, resonate with folks, is that we need to support the program.
Thank you. So blood's not cheap. A unit of packed red blood cells is about $350 to $400 thereabouts. A unit of whole blood is about $600, so it's not cheap. I mean, like I said, last night I gave that guy 4 units of blood products, so that right alone was probably about, I don't know, $2,500, and I'm sure he got some more since then after I left. So it's neat. The other thing with platelets, we run out of platelets. There's times there's only 1 bag of platelets in the whole city of El Paso, or the whole region. When we had September the 11th hit, many years ago now, and the helicopter or the planes weren't flying for 3 days, we stopped all elective surgery in the city of El Paso at every hospital just to be ready for emergency surgery. We went 3 days with 1 bag of platelets in the region. We finally got a bag of platelets from Tucson. The Border Patrol was able to fly us the platelets. So it's usually not the red cells we run out of, it's the platelets, because we use it not just for trauma, we use it for patients that are, have hematologic problems like lymphoma, leukemia, things like that. In September 11th, you saw the people running to donate. They actually had to throw away thousands of bags of blood only because everybody died. They thought there was going to be victims that were alive and they're going to be doing that, but they didn't. If you heard my press conference that Saturday, one of the things I emphasized, if you're going to give blood, please don't come to the hospital, because people all want to run to the hospital. That's not where you donate. They go to, it's got a new name, I always call it UBS, but it's Vitalent, I think now. But it turns out actually we don't use as much blood as we think we need for these mass casualties, but thankfully none of the blood went to waste after August the 3rd. We were able to use it for various other reasons, but we didn't use that much blood today. I mean, I can have 1 trauma patient, I can use 100 units of blood in one day. With all those patients, we only used 59, so we were very fortunate. So the other thing we learned with the military is we do a 1-to-1 ratio. Every unit of blood, for somebody that's bleeding a lot, every unit of blood, packed cells, I give 1 unit of plasma. You heard me say I gave this guy 2 and 2, then 2 and 2. We do that, and that's one of our goals. We saw that actually improves survival, and that came out of the military. So that's what they do in the military. So now in the military, they were doing the 1-to-1 ratio, but now they're even doing 1 step above. They're giving the whole blood if they can. But they have a walking blood donor supply in the military. And they all these guys, we got all the A's here, all the B's and whatever. You guys need to donate. And they just, these guys are loyal to each other, and they donate as fast as they can. So let's move past blood utilization. I know it's getting a little late. Another piece of his artwork. I like some of his black and white work, actually. Sort of neat. Okay, I think this is a very telling slide, and I know there's a lot of lines and graphs, but we're going to make it simple. If you look under A, that's the Afghanistan conflict from 2001, and down here is Iraq, which really started around the end of 2002, probably 2003, and then we have a gap here because we sort of went away from Iraq, and then we sort of came back a couple of years ago with a few troops. So the main line I want you to look at is this orange line. So going higher is a good thing. That means survival of very severely injured troops. Look at this increase. Increase, and then it sort of plateaued on because Iraq sort of faded out and Afghanistan persisted. So what made this difference? There's the article right there is in JAMA. You can reference it. But what we found out is we started using more rapid transport of the patient that was injured, the soldier injured, to a definitive care place in Afghanistan or Iraq. Number 2 was mainly use of tourniquets. Number 3 was the 1-to-1 blood transfusion ratio. And now using, probably in the last 7 or 8 years, using the whole blood. So we're showing increased survival in our troops over the years. One of the things which history repeats itself, and I hate to say that, is with every war, we forget what we learned from the prior war. So, there was an article that just came out last month in one of my trauma journals, how the military, which did an incredible job, and they still are, but they've downsized. There's only 25 fellowship-trained trauma surgeons in the whole military right now. 25. So we had a major attack, we would have to mobilize again. So that you can't use these guys all the time. So a lot of these trauma surgeons that were very active are now at these bases, maybe doing 4 or 5 operations a month. So they're losing their skills. So we're trying to embed some of them into our civilian trauma centers to keep their skills active. So when this happens again, because there's going to be a war again, it always is, we need to be ready. Because I can tell you, China and Russia, they keep their guys trained. It's a different type of healthcare environment. But this is really telling about how we learned and how we saved so many soldiers that would have died. Okay, move on, please. Another picture. Some more work. Okay, so I laid all these last few slides. The future is now. Some of this stuff is really just like Star Wars, cutting edge stuff. And a lot of it we did learn from the military, because it's the only good thing of a war. We learn to take care of our patients better based on what we learned from war injuries. So this patient had an aortic injury. The aorta is the big artery that comes out of the heart, and it's called the thoracic aorta. When I grew up as a trauma resident, we would have to take this patient to the operating room, open up their chest, maybe put them on cardiopulmonary bypass if they were stable for that, and then put these big stents in, about the size of a water hose, to replace the injured aorta. 95% of these people died at the scene. The 5% that would survive to get to the hospital would die within 24 hours. Just think about it. UMC sees 3,000 trauma patients a year. Not all have these injuries, of course. They have different types of injuries. But we would have to do this major operation in which 25% of those patients that survived to have the operation would be paraplegics, meaning they could not walk because their blood vessels, they had ischemia to their spinal cord with this major operation. 12% would have renal failure, meaning they'd be on hemodialysis for the rest of, hemodialysis for the rest of their life. So 25% paraplegics, 12% renal failure for life. Terribly morbid, but at least they survived. And it was like a 6-hour operation. And patients would come back out of the surgery sicker than they were before the operation. Now we put this little catheter in their groin. It's called TEVAR, thoracic endovascular repair. We put a catheter up, go up to this area here. We deploy this stent that expands on its own. It's a 90-minute procedure. It's not even an operation. It's done in a catheter lab. And they go to the ICU and they go home in 2 or 3 days. This just happened probably less than 10 years ago. We probably see 2 or 3, probably about 2 a month now. And these people are walking out of the hospital. And in the past, they've been in my hospital for a month if they survived. Because they usually had other injuries too. I mean, they don't just have this injury, they had other stuff. So just amazing. Next slide. We're doing a lot more endovascular stuff. This is really neat. And I'm not sure if I believe it in it or not. It's called REBOA, and there's the name for it. It's very similar to what I just described, but we put a catheter up your groin, up to your aorta in the belly. So your belly button's here, your aorta's here. It bifurcates here to become the iliacs. So if you have major bleeding in your belly or your pelvis, you can put this catheter up there. You inflate the catheter, and it tamponades the bleeding. We're still not convinced it works good enough that we should be doing it. We probably overuse it. It's very expensive. It's invasive. When you have a complication, it can be a major complication, but it can be life-saving. And this came out of the military. In the past, we would make a big incision and clamp the aorta and do this stuff. A 97% fatality rate. That means you had a less than a 3% chance to survive if you came with these injuries. Now, once again, we're putting this up somebody's groin. So we're learning who really needs it, when should we do it. We're still learning that. We don't use it yet at UMC. We're talking about it. We're actually talking to one of the flight companies where they're actually going on a patient in an extremis. They're going to do it in the field at the scene, and then we'll work with them there. So we'll see how that goes. There'll probably only be a couple of patients a year that would meet that criteria. But just amazing. Next slide. This next slide's got a bunch of pictures here, so I'm going to go through them. These are really neat stuff. Let's go at the bottom one. We probably, just last week I saw 3 patients in our ICU that had this, and 2 of them were trauma patients. These were people with something called ARDS, acute respiratory distress syndrome, where their lungs are just so bad, either from pneumonia, the flu, or most likely from trauma. Remember I talked about that general? He did a lot of the early research in the 1970s about ARDS in Vietnam. It was called shock lung back then, but we got different names for it now. So ARDS. We put these patients on this. We actually may have to chemically paralyze them because their ventilator settings are so great, and this helps clean up their lungs. And if it gets worse, we put them on this device, which is hard to conceptualize, I guess, but that's actually a patient in there, and we flip them over completely prone. We prone our patients to get the best side of the lung that's working. So they'll be in a prone position for like 12 hours, and I guess like cooking, you flip them back like rotisserie. We flip them back and forth until their lungs get better. But once again, when somebody gets that, that's a 40% mortality. So really sick people. One patient, without giving you any other information, was not trauma about 2 weeks ago, was so bad due to the flu, so get your flu shot, was so bad he went into ARDS. That device wouldn't work. We actually had to have this, this medical crew from San Antonio fly him to San Antonio, and they put this device called ECMO, which is basically putting bypass for the heart and the lungs until the lungs get better. They used to do that a lot on babies. Now we're doing it on humans. At some point, we'll probably start doing that at UMC. I know in Albuquerque they're doing it. I know they're doing it in Tucson. But maybe 1 or 2 patients a year would benefit from that. But this guy had the flu was so bad. This device here is a chest tube setup where somebody is bleeding in the chest. We put a chest tube in, we suck the blood out, and then we can auto-transfuse their own blood back into the patient. There's a little container there that we use. I think like 6 patients that day in August got chest tubes. Most of them got double chest tubes. There's another device here called a greenfield filter. People get blood clots in their arms and predominantly their legs after trauma. And the clot can go off to the lungs and kill them due to pulmonary embolism. So we put this little filter in their inferior vena cava to catch the blood clots. In the 1970s, this didn't exist. The surgeon would have to go in there and put a clip across the inferior vena cava, which was not a good thing because then their legs would swell up. Now we put these filters. And now our filters are temporary, so we can put them in and when the patient gets better, and we take them out. Same day. Coming in, the radiologist goes in, puts his catheter and pulls it out. Something that was popular in the 50s was rib plating for rib fractures. We know that somebody above the age of 65 has 3 rib fractures. Their mortality is 25%. Every rib fracture over that increases the mortality by 7%. And sometimes we have patients with 8 to 10 ribs on one side and 6 to 10 ribs on the other side. So high mortality. They used to plate them, and now we're plating them again. We'll probably do one of those every month or so. This, I know these are just numbers here because it's really just a device. We put an arterial catheter in somebody and we hook this little, the catheter to this device so I can measure how good their heart's pumping, how much fluid I need to give them, do I need to give them a pressor agent. In the past, we had something called a Swan-Ganz catheter, which is extremely invasive. I can't remember the last time we used a Swan-Ganz catheter. I don't even believe them anymore because nobody knows how to use them. And we used to have to stay up all night as residents trying to calibrate, titrate it, and the balloon would pop. We had to get a new balloon in. Very invasive. It caused hemoptysis because it migrated too far and the patient would be bleeding in their lung. Now we just hook this up to the wrist. And now there's actually going to be some devices that just put on your finger that you don't even need a catheter. Next slide. We're almost done. I keep saying that. We're almost done. Okay, these two are very neat. I've not seen either one in real life. This one here is basically putting foam in your belly. So patient's bleeding, you can't operate obviously at the scene. A paramedic, and they're still doing this with animals. We're not doing this on humans, with pigs. Somebody's bleeding, they'll put a catheter in there and they inject this foam. The foam will solidify over all the organ. That's the transverse colon, that's the liver. That's the stomach. It basically just freezes or clogs everything up. And then we go in, we open them up, and then we can pull this cast out and just operate on the part that we need to. Really neat stuff. We do have a lot of clotting agents we use all the time that we just squirt in to help clot, but nothing like that. And then lastly, we're actually doing something, I'm not, but they're learning how to do it, and they're going to start with humans, I think at University of Pittsburgh, suspended animation. Patient comes in, they're in hemorrhagic shock, they're going to die. There's no way you can get them to the operating room in time to save their life. They'll just put these catheters in and they'll just freeze them. They got some chemicals and stuff with it. It's not just you're freezing them. And then while they're frozen, basically you're suspended in animation, just like Coma, the movies and stuff. And then we can operate leisurely, sort of like what we do with cardiopulmonary bypass, but less aggressive. But that's probably in the next 10 years or so to save some of these people. And I think we have one more slide maybe. Okay, keep going. So this is my last Tom Lee slide. It's one of my favorite ones. It's not very well known. It's called the Altar of Earth. It's West Texas, an area that he loved. If you look closely, there's a hand there. It's the hand of God. I think that's really appropriate. And I use that. I got a talk I need to give tonight about the August 3rd shooting. Just El Paso strong. I think that's just the hand of God coming upon us in West Texas after this event. I think it's a beautiful work of art. I've always shown it on my slides. So I'm done. I know y'all got to get back to class or back to work. Thank y'all.